All right, guys, welcome back to the Gyno Gurus. So today we're actually going to be breaking up what initially was supposed to be one episode into two episodes. So we did just decide to do this quick little intro to kind of explain how everything was going to work and just give you guys a little outline of what we were going to be talking about. So for today's episode, we're going to be starting out with just kind of a general overview of what insulin resistance is, kind of what we talked about last time, but in a little bit more condensed form. We do kind of get into some of the deeper pathophysiology initially. So if that is something that doesn't quite interest you, you can go ahead and just skip ahead to about 13 minutes. And that's when we start talking about signs and symptoms and testing. And after we're done talking about signs, symptoms, and testing, we're going to go ahead and wrap up the day today. And next episode, we'll be talking about supplements, diet, lifestyle, all of that fun stuff. And then later be talking about medications. So thank you so much for watching. And I hope that you guys enjoy the episode. Welcome back to the Gyno Gurus, everybody, where we talk about all things general and reproductive health. If you missed our first episode, first of all, shame on you for not watching it. Second of all, just kidding, not shame on you, but you should go back and watch it. But we're kind of doing a little series about just metabolic health and insulin resistance. So we're just going to kind of give a brief overview of our last episode if you missed it. Basically talking about what insulin resistance is at a very high level, and then we'll kind of get into more of the nitty-gritty details. So Dr. Mandela, if you just want to give us a really high overview of the insulin resistance episode that we talked about, and then we'll kind of get into the next thing. Yeah. So take it away.
Thanks for the great intro, Alex. So insulin resistance is what happens when your body's insulin response doesn't bring your glucose down or lower it as it would normally do. So you need high levels of insulin to do that. Now, I'm going to just give us a little overview of how glucose is regulated. Of course, glucose is critical to have adequate glucose in our blood. If our glucose level drops too low, it's really not compatible with life. So our body always will make sure we have some glucose circulating around, no matter what it takes to do that. So as a matter of fact, just to kind of relate one thing, so red blood cells are cells that only utilize glucose for metabolism. And if your red blood cells weren't working, you couldn't transport oxygen, and that'd be the end of you. So,
it's not funny. It's not funny.
Yeah. So no, but it's very critical serious, to have that glucose around for that reason alone.
And you're saying because they need energy.
They need energy. Yeah. Absolutely. Your brain uses glucose a lot, but your brain and your heart, but your brain and your heart can also use non-insulin energy, and we call those ketone bodies, and those are really derived from the breakdown of fat. So if you were in a starving state, you would still be able to get energy to your brain and your heart, but your red blood cells would still need glucose. So you have to produce some glucose, and also other organs need glucose too.
Yeah.
So if we look at how this is regulated, you have the two major hormones are insulin, which most of us are familiar with, but insulin is produced when we take in a glucose-containing meal in order to prevent the glucose level from going too high. Our body produces insulin. So when we take in the glucose, what does our body do? So we can either utilize that glucose by burning it for immediate energy, or that excess glucose can be stored, okay? And if we're overtly diabetic, we can even excrete glucose, but that's very pathologic. And that's why, like, nowadays, not so much, but in the old days, diabetics would always have test strips to test your urine for glucose, because when your glucose gets above about 200, it'll start coming out of your kidneys. As a matter of fact, one of the diabetic medicines actually works, or one class works by causing you to excrete glucose. So
Lots of UTIs.
lots of UTIs.
Yeah.
But anyway, so you have insulin, and insulin will cause your body to either break down glucose to the real energy currency of our body, which is called ATP. And ATP is what really drives the chemical reactions in our body, provides the energy for that. So one thing, it can provide immediate energy, but if you have enough glucose around, then what do you do with the rest of it? So your body will store it as a animal starch, primarily in the liver, but also in the muscle, called glycogen. And glycogen is basically glucose that is what we call polymerized or linked together. Okay, and the advantage of having glycogen around is when your glucose level drops when you're not eating, you can take that glycogen back and take the glycogen and rapidly convert it back into glucose.
Mm-hmm.
So you can maintain the glucose in your bloodstream. And then for longer term storage, insulin will cause fat formation. So, and they call that lipogenesis. Okay, so it turns sugar.
Insulin will cause fat storage, or are you talking about glucose will cause fat
Well,
storage?
insulin's effect
will
cause fats to form.
Fats to form. Okay, got it.
And the other thing that insulin does, it also inhibits the release of its counter hormone, glucagon. So glucagon, it does basically everything insulin does in reverse. So glucagon causes the breakdown of glycogen to glucose. Mm-hmm. It causes glucose to be formed by amino acids. So that's an alternative way to make glucose, is you convert amino acids, which are the breakdown products of protein. And then you also get ketogenesis, which is the breakdown of fat into those usable energy source called ketone bodies. Okay? Mm-hmm. So, okay.
I also just kind of wanted to back it up
just
for a minute, just because I do think that, some of the words can be kind of big and confusing, but I think just from a high level, just kind of going back to just what insulin resistance is, why it's important, kind of basically what we talked about in the last episode. So, basically high level, whenever you have insulin resistance, you're producing a lot of insulin from your pancreas to keep your glucose in check. So all these things don't happen. But then what can happen is whenever you get desensitized to, the receptors, all that stuff, you have increased levels of insulin, and eventually your pancreas gets tired and it stops working. And then we have all the issues that we talked about in the last episode.
Exactly.
Yeah.
So we'll summarize insulin resistance as basically your body doesn't respond to insulin as it should.
Yep.
And this leads to a lot of metabolic issues.
Yeah.
And so what happens is you will be, your body winds up having what's the best way to say this? You need to make more and more insulin to control your glucose levels.
Yeah.
And like you said, your pancreas can't keep up with it. And that leads to diabetes, or pre-diabetes, and then diabetes.
Yeah. And I mean, are the girls who, reproductive age that I specifically see, since I typically see a younger population, would be PCOS, things like that.
Right.
So, I think with your population, since, your patients have kind of grown with you, which we talked about before, but it's kind of funny because whenever I was your student, I got really used to your population, and now that I'm practicing on my own, it's my patients are growing with me and they're kind of my age, so I'm dealing with their subset of issues.
Exactly,
and it's different. And I think that just kind of also goes to show insulin resistance throughout the lifespan. So for the girls that I see who are around my age, it's like, what do I see? Well, I see PCOS and prediabetes. And for you, it's like that could be different. That could be dementia related, Alzheimer's. Not to say that's where that's going. But you see kind of the long-term implications of that. But yeah, so all that to say, like I said, we talked about that in the last episode. So we don't have to harp on it. But I do think it is just kind of important to just kind of rediscuss like while we're, in the series talking about it.
I think we're going to revisit these issues because it's not the front of everybody's mind.
And they're hard. It's hard to understand. Like it's
these
complex.
Are very, very complex. This is just a very superficial overview of what goes on in our body to maintain glucose. There are other hormones, but these are the two main hormones.
Yeah.
And basically, you can think of it this way: insulin is a hormone of energy storage, and glucagon is a energy of glucose production. In other words, to mobilize those stored energy areas, your glycogen, your fats, to provide energy the body needs when you're not eating. Like, so when you're fasting, you still have the energy to do your metabolic processes, to move around, to think.
Yeah, but it's just so complicated. And I think that's like, it's hard because like we're kind of starting off, I feel like, just this series and honestly our podcast with one of the most complex, like poorly understood issues, I feel like, in healthcare right now, honestly, because it's such an epidemic. But we really just don't have I feel like a lot of people, clinicians included, like don't really have like a clear answer of like, why does this happen? Like we know what it is, but it's like, why does it happen? So yeah, all really interesting stuff. Definitely gets in the weeds with like the, pathophysiology, but still good to, understand, especially when you're treating it like, like we are. So,
this is clearly, insulin resistance is clearly a problem with the modern lifestyle because we evolved in an environment of energy shortage. And so it was a major advantage for survival to be able to have our body respond the way it does. But when in a time where we have lots of energy around, it leads to pathologic processes developing. And if you go back a couple hundred years, diabetes was basically an unheard of disease. Fatty liver, fatty liver did not exist really till the last 40 years. It's clearly a lifestyle issue of our modern lifestyle. Excuse me, processed foods and too much sugar.
But you know what I think is interesting, and I don't know if we've talked about this before, but like we do see like there is like data and literature coming out, especially like in the realm of like PCOS being hereditary, and basically like female babies born to women who had PCOS at the time of conception are more likely to have PCOS and metabolic issues later in life, and that's due to androgen, exposure in the womb, like a smaller kisspeptinergic system being developed. There's a whole bunch of things that go into it, but just the fact that you're right, I think it's a combination of lifestyle, the culture of like food that we live in, processed foods, GMOs, all the things, but then also recognizing that, hey, like there is also a genetic component to this that is responsible for,
right. So
you're compounding everything just on top of each other.
Well, there's genetics, and as you alluded to, but you didn't specifically say, the epigenetic factors, and those are the environment in the womb that actually promotes the manifestation of your genes more.
Yeah.
So, very good point.
Yeah. So, kind of moving on. So today we were really thinking about just talking about signs and symptoms. We were going to talk about what the testing looks like to, be diagnosed with insulin resistance. And then also talking about things like lifestyle and supplements and stuff like that. And then I know we had kind of talking about medications at a later date just because that gets so into the weeds and is so complex. complex. So, that will definitely be, I think, a whole episode in itself. So yeah, I think kind of starting just, with what are the early signs and symptoms, just like off the top of my head here. So we talked about this before we started, but, specifically increased abdominal circumference, cravings, goodness, brain fog is a big one. I remember in my FEM training, which is, shout out to Fertility Education Medical Management. They talked about how insulin resistance starts in the brain, and that some of the first signs and symptoms of IR, which is insulin resistance, is actually brain fog. And that's something that I always keep in the back of my mind whenever I have somebody come in and they're like, I just feel like I can't think straight. I'm like, have you had your insulin tested recently? And they're always like, no. So yeah, brain fog. And then, I think also just as clinicians, recognizing like not just symptoms, but also signs. So we talk about like the darkening, velvety skin, which we call acanthosis nigricans, which is a hallmark symptom of insulin resistance. I know that we had talked about this beforehand, but
so acanthosis nigricans,
acanthosis nigricans
is this darkened skin found in certain skin folds.
Yeah, like groin folds, armpits, stuff like that. So from our perspective, what do? We do breast exams and we do pelvic exams. So we can see it in the armpit region, and then also you see it in the groin folds. And that's something that I always look for, regardless of, BMI, anything like that. It's just a good thing to be aware of. And I actually have caught several cases where, glucose is normal, hemoglobin A1C is normal. You see like the darkened, velvety skins and the, skin folds, and I test our insulin and it comes back as, very elevated.
Yes.
So, that's just something to be aware of.
That's the canary in the coal mine.
Yeah. So, but the thing is, it's just, sometimes you don't have symptoms. Like sometimes there are no symptoms and you just have, signs, or honestly, sometimes neither. But, of course, the other things like trouble losing weight, all of the basic stuff like that that's associated with kind of the pre-diabetic realm of signs and symptoms. But
or what's termed metabolic syndrome.
Metabolic syndrome, yeah. So yeah, those are kind of just a few of the higher level, like overall things that at least I look out for and that I see. But I don't know if you have anything to really add to that.
Sure. Well, I'm just going to briefly go through metabolic syndrome again. So you're going to have elevated triglycerides, low HDL, you're going to have high blood pressure, increased abdominal circumference, and abnormal glucose level. So that's also a sign or a clinical sign to be aware of. If somebody has that, they, almost certainly have elevated insulin levels. And that's really the driver of all of this stuff.
Yeah. And I'm just actually curious, like in your practice, because I know a lot of the times we talk about, okay, well, we don't test what you're not going to treat. Do you test cholesterol, triglyceride levels, or do you let PCP do that? Because I know we just do gynecology, but I'm just curious because everyone has a different...
more and more I test.
You have? Okay, I was just wondering.
I definitely think it's worth testing because a lot of, especially younger women, their PCPs are not going to test. Yeah. And if you look at...
not even triglyceride levels. Like, you don't think they test cholesterol? Because I feel like I do see that they do, but not insulin levels.
Well, they definitely don't test insulin, but a lot of them don't test. Like 20-year-olds, a lot of them haven't been tested for.
We're gonna have all the PCPs coming for us in the chat saying yes, we do.
Yeah, not to say no. There are certainly PCPs that do, but there are a lot that don't, and that the problem is that when you develop like coronary artery disease, it doesn't happen over a few years. Right. Even in young children who unfortunately
we talked about that.
Have died in car accidents on autopsy. They can see fatty streaks developing in their coronary arteries in 8-year-olds. So it starts young, and so it's a big impact later on in life.
Sure, that makes sense. Yeah.
Yeah. So
I was just curious because I do what you do. So. But I do feel like a lot of the times, because like since we don't treat it, I usually don't test for like the cholesterol stuff, but I'm usually like follow up with your primary because if I don't treat it, I'm not going to test for it.
Yeah, but I think it's reasonable to test for it.
Sure, that makes sense.
Because then you can identify it. And you can direct the, even though I don't prescribe statins as a rule, I would tell a patient you should follow up
their primary, and that makes sense. But yeah, so anyway, all of that is, but yeah, anything else to add for like signs and symptoms or anything else that you'd really like want to look out for? Because those are pretty much the things I had
No, really,
thought of.
that was a good overview.
Yeah.
I'll add one little thing here. The impact of sugar on the brain is, I'll say, used to be appreciated a little bit more maybe than we did now until recently. If you went back many years ago, I'm going to say like the early 1900s, it was recognized that children who had seizure disorders, if you put them on a ketogenic diet, meaning pretty much no sugar at all, their seizures went away.
Really?
Yeah.
That's crazy.
It's well known. And then we kind of moved away from that as seizure medicines have been developed. It's easier to give somebody a pill than to, because it is hard for especially a young kid to not be able to have a soda or whatever. Realistically.
Trying to keep realistic expectations. Yeah, of course.
So,
makes sense.
Yeah.
Okay. Well, that's good. I think the thing that sticks out the most to me, honestly, was like the brain fog. I just think that's like so fascinating. But like we've even talked about that before with like, like insulin resistance and like high glucose and stuff being like type 3 diabetes, or dementia being type 2 diabetes.
That's the concept now.
Exactly.
Is dementia's type 3 diabetes.
Right.
And one thing we didn't say also about insulin is the fact that high glucose levels and insulin levels are cancer promoters. There's higher rates of cancer too. So not only heart disease, but cancer too.
Yep. Yep. So anyway, so I think we can move on to testing. I think that we
absolutely
went, pretty thorough through that. So testing, we kind of briefly touched on it last week, I guess. So basically insulin testing and fasting insulin, and then you're doing an OGTT. Of course, we know glucose and hemoglobin A1C are important, but it doesn't give us the full picture. But having all of them is ideal. I think we were kind of talking about this prior, but the thought of doing insulin by itself versus doing like an oral glucose tolerance test with insulin response, why would you do one over the other, and how do you kind of make that decision?
Well, first you have to look at the patient.
Yeah.
So if you have a patient who is has a normal body mass index, you have no other signs or symptoms, it probably is not really too reasonable to go through a
whole OGTTI.
You have somebody who you identify who's at risk. That's the time to do it. So, generally what I do is I do a metabolic profile, which includes a glucose level. It includes liver function tests, renal function tests. I would also get a fasting insulin level and a hemoglobin A1C.
Yep.
So let's just kind of educate our audience about each of these things. So I'm going to go back to a concept that we talked about previously. There is a difference between normal and optimal. Normal is a statistical term that says the population, 95% fall within this these confidence intervals, and that's normal, okay? But it's not necessarily optimal. And if we look at fasting blood sugar, for example, when I see a fasting blood sugar above 85, that's not optimal. So that's of some concern to me.
Yeah, but if it's under 100, it's statistically
under 100,
normal.
Exactly right, Alex. That is perfect. So pre-diabetes is 100 to 125. So, but that's less optimal than having a sugar, say, that's 95, but it's not truly optimal. So it would be, I'll say, fairly unusual to see an elevated insulin in somebody whose fasting sugar is under 85.
But we have seen it. Yes. I have seen it.
Yeah, it does happen.
It does happen.
It does happen. So you don't put all your eggs in one basket.
Yeah.
Okay, so you have to look at the complete picture. Okay, so you have on your metabolic profile, you have your glucose level. You want to look at the liver function tests.
Yes.
the ALT and AST. Although normal in most labs is going to be, of those two liver enzymes are going to be into the low 30s, optimal is really probably less than 25 on both of those.
Yeah.
And when I was in training in the previous century,
It actually was, though.
it was the previous century. The normal ranges for liver function tests were different because it's based on the population data.
Yeah.
So as the population has gotten heavier,
Which is so important to recognize because it's like, I mean, there's other parameters that are outside the scope of what we're talking about now, but like it really is, I mean, like you're taking a group of people who, like you said, it's like have, you know, are very, very overweight and it's like have a lot of adipose tissue and it's like, but that's like normal, but it's like, what is normal versus like
exactly
healthy?
right.
Like, so it's definitely, yeah.
Exactly right. Now, a hemoglobin A1C is defined by a cutoff like 5.7 or higher is going to be, I think, 5.7 to what, 6.
I think it's 6.6.
6, I think, is the mid sixes is prediabetes, and then above that is diabetes. And those are just arbitrarily defined.
Oh, Logan looked it up for us.
There we go.
6.4.
Yeah, 6.4 is.
And then over 6.5 is diabetic.
Diabetic.
Yeah.
So, but those are just, they're I don't think statistical normals. I think they're just defined as that. And the hemoglobin A1C, which we talked about previously, so I'll go through it briefly, is the amount of glucose that has bound to the hemoglobin molecule in a blood cell, red blood cell. And that occurs over time. The average life of a red blood cell is 3 months. So they say a hemoglobin A1C reflects what happened over the last 3 months of glucose control. So if there are things that can make them falsely high or falsely low, which we talked about previously, I'm not going to go into that. But basically, it gives you more of a long-term perspective of glucose control. And then there's insulin level. And insulin level, I think, is the most sensitive finding if you do like on routine blood work, a fasting insulin level. If your fasting insulin level is below 5, you can be highly confident that that person, as far as glucose metabolism, has no issues.
Yeah.
Most labs define normal up to an insulin of 25. And that means that if you're 15 and somebody looks at it, they'll say you're normal.
Yeah.
But it is clearly not optimal.
Right.
You know, so, and then those are easy tests to do. And then there are tests that monitor things like after eating, which is very important, but not so easy to do.
Yeah, a little less fun, but still important. I mean, so now we're kind of getting into the realm of like OGTT and OGTTI, you know, FEM, which is the Fertility Education Medical Management that I talked about earlier. They do research through the RHRI, which is the Reproductive Health Research Institute, which we had talked about. So they actually, I can't find a lot of data on specifically the glucose insulin response outside of their own research. But I will say in my own experience, because there is data for the OGTT, which is technically like the most sensitive indicator of prediabetes, is doing the OGTT.
Oh, yes. For a long time.
That was a gold standard.
That was the standard. Before hemoglobin A1C was around, they used the glucose tolerance test.
Yeah. So the glucose tolerance test. Yeah. What does it stand for? Oral glucose tolerance test.
Yes.
And then the I at the end of it is with insulin response.
So let's explain what that is. So a glucose tolerance test is a test where you get a fasting glucose level, and then you give a patient a known glucose load.
Usually 75 grams.
75 is standard for non-pregnancy. I think pregnancy they use 100, but
I can't remember. We don't do.
It's been a while since I did.
We don't do OB,
so
over my head.
And then they measure at some will do it 30 minutes 1 hour, 2 hours, 3 hours.
The one that we do
And
is
then
30,
you
it goes up to 90 minutes. So 30,
Yeah.
60, 90,
Yeah.
and that's it. Yeah.
And then some go out to even 5
5
hours.
hours. Yeah. Yeah.
And to sit around the lab for
That's
5
a long
hours,
time.
long time. Big
Yeah.
commitment from a
But
patient.
I will say, like you said, you know, if you have somebody with an insulin of under 5, it's like you can be reasonably assured that it's, you know, they don't have insulin resistance. But I will say I had a patient who was very symptomatic. Her insulin initially was under 5. We did the OGTTI, and it was very clear that there was insulin resistance. Her insulin went from 7, because the second time we did it, it was 7 to 160 in 30 minutes after 75 grams of glucose. So all that to say, like, yeah, you can be reasonably assured, but that's why it's important to just know your patients, know what to look out for. Like, do they have brain fog? Are they having like fatigue swings? If their glucose is yo-yoing around, like, that's not going to make you feel very good. So just really listening to them, like tailoring the testing to their needs which is what we do.
Yes.
Like, as providers.
Like if somebody says, you know, they eat a meal and then a few hours later
they're conked
they're
out.
really feeling badly, that might be an indication for the 5-hour glucose
Sure,
test, because the insulin, what happens is, as somebody, especially if somebody gets insulin resistant, they don't regulate their glucose as well as somebody who's not insulin resistant. So there's an overshoot of insulin production in the beginning to try and get that glucose down, and then that insulin
is still there and the glucose crashes.
Right, the glucose crashes, and that's why you give, like a diabetic who gives themselves too much insulin, it's basically the same thing.
Yep.
So then you have to give them some sort of sugar, or they'll won't do well.
Yeah, and that's kind of where you get into like the whole continuous glucose monitoring with the, you know, CGMs that you can put on your arm, which I think those are very useful, especially for, you know, monitoring. When we were talking
absolutely.
about that,
I think CGMs are really the best test. If somebody is trying to manage this condition, they'll see what causes their sugar to go up so high, and then they can manage it. There's certain people who are sensitive to particular foods or fruits or whatever, you know, and they'll say, you know what, I can't eat cherries, but maybe I could tolerate an apple.
Apples to oranges, literally.
Yeah, you know, so you could learn what's going on with your body with a CGM. You also will see that other factors play into like sleep. Sleep is the big one, or one of the very big ones. If you're sleep deprived, your ability to regulate your glucose is going to be much more weaker than if you get a good night's sleep, or other stresses. And probably, I'm sure if somebody was traveling and had jet lag, that would probably be a big one.
Problem.
Yeah. And also illness. I mean, if you get sick, that would influence it. Although sometimes an elevated sugar might be an appropriate physiologic response
for illness.
you know, so you wouldn't necessarily not want to see that happen.
Right. Makes sense. Yeah. So just to kind of recap, so, you know, we talked about basically the metabolic profile and hemoglobin A1C, where it's useful, which is, you know, all of these together are good, but they're all good to have together, including the insulin, you know, OGTTI in specific patients. And then the CGM, honestly, I feel like is useful for pretty much everyone.
I think a CGM would be a very useful thing. And although I've never personally worn one, I've been thinking about getting one.
I've been thinking about getting one too. Just to see. I mean, it's good to have like good data. I mean, because like everyone is, you know, I feel like in a way probably sensitive to like certain things, like certain fruits, foods, whatever. And you know, the more data you have, the better. So
absolutely.
I think that the CGM is really an appropriate thing for anybody, even someone who doesn't have insulin resistance or issues with glucose metabolism. So
yes, and then. And another thing that influences insulin sensitivity, a big one, is exercise. So you can, if you had a CGM, you probably would it would be a reward for your exercise and motivate you to exercise more. And that's really what the CGM is sort of about for a lot of people, is it gives them reward for good behavior.
Exactly. Well, and then it's like having that, instant gratification. Oh, Good to see you again. I hope that you guys enjoyed the episode. So like I mentioned earlier, we're actually going to be talking about supplements, lifestyle, things like that next week. And then the week after, we'll be getting into medications and some of the other things as well. I hope that you guys enjoyed the podcast today, and we'll see you next time.